Thank you, Mike, and thank you, Rupin. I'm not so much on the fringes of hemostasis and thrombosis. This is a very important part of my life, but it's not the only part of my life. So we still do a lot of other hemostasis and thrombosis, but I have obviously a particular interest in microangiopathies, and that has developed over the last 10 or 12 years. So I'm not today going to give a TTP talk, you will be pleased to know. But there are some things that have changed, particularly in the last couple of years, and that will change in the next few years that I think are relevant, especially to the UK audience, because a lot of it is being driven out of the UK, but there is a truly collaborative working group internationally made up of about 30 leaders within this field. The most recent publication that we've had is in JT&H, and again, opening up a bit of controversy, there is 29 authors internationally who have tried to alter the terminology and definitions, not alter, but really put into onto paper what we understand by TMAs. And that is important, particularly within the era of undertaking clinical studies and, more importantly, clinical trials, as there are a number coming through. So we don't use the word acquired TTP anymore. We're now going to use immune-mediated TTP. And let me tell you, this has taken months of going backwards and forwards and going backwards and forwards. It's the same thing, but it just defines that it's an antibody-mediated process for TTP. Congenital TTP doesn't change. But within the whole sphere of these conditions, we now have at the forefront this condition or this terminology of TMA. And this is going to become increasingly important because it's not just TTP. There are many conditions we've seen over the years that are not associated with a true deficiency of ADAMTS13. And while many have thought that you define TTP in these cases with normal ADAMTS13, that makes absolutely no sense. If we have, since the end of the 1990s, very important literature that suggests TTP is a condition associated with an absolute deficiency of ADAMTS13, they then cannot have normal ADAMTS13 and still call them TTP. So we have to keep looking for the underlying pathophysiology of these many patients that present. And over the last 5 years, in particular, with the advent of eculizumab, we now know that we have this secondary rare group of HUS. Now this will cause some level of controversy because of course we're stepping on the renal team's feet here, but be assured that haematology, certainly in the UK, see probably more cases of atypical HUS, that was the previous definition, but many still use, than the renal physicians. So we've changed from atypical HUS to complement-mediated HUS. And the reason for that is that there are 40% of patients for whom no mutation can currently be detected, but they will still respond to complement therapy. And that may alter in the future, and we may have to change complement-mediated HUS. But for now, it fits quite well. And we've moved away from E. coli associated or STEC HUS to infection associated. Time and time again, we have cases which are not O157, and that is typically how infection-associated HUS has been thought of in the past. We have many other bugs. There is pneumococcus, albeit rare, particularly in the UK. There's Campylobacter, there's Shigella, there's Salmonella, and there's other subtypes of E. coli. So this aims to try and encompass all of those conditions. And the treatment's important. So the treatment for those cases is supportive. With regards to the national structure for TMAs, there's two kind of competing groups. So we have the complement-mediated group of HUS and we have the TTP. So Newcastle run or dictate who can get eculizumab for patients who have complement-mediated HUS, but they are not a TMA centre. So within haematology, there are changes currently within England, so we are trying to adopt a national service for the condition, which makes perfect sense. From the registry, the UK TTP registry, we know there's at least 45 centres in the UK that look after TTP cases or TMA cases. And clearly, there does require that there's a level of expertise and process within trusts for patients to actually do very well. So this is going to go through a tender process next year. I don't know who's going to be adopted. It could well be that we don't get it, which would be quite funny in a way. Not for us, but that will be decided by the commissioners. But there will be probably about 10 sites in England who will exclusively look after TMA cases. Why does that matter? Well, in fact, Liverpool adopted themselves as a TMA centre, a TTP centre a few years ago, and it was on the back of a number of cases of patients who died. So their mortality was about 40%, and within the UK for TTP that was replicated in many of the senior centres and teaching hospitals. So they have now adopted a process, they have backup from their managers, and their mortality is now 0. So that's why we need to progress this process. So that's some of the politics. So getting back to the clinical and the science of TMAs, we now know that there is an absolute requirement for a diagnosis of TMA, of thrombocytopenia and microangiopathic hemolytic anemia. That opens up a differential, but in the first instance, if we have patients like that, it's important to exclude a TMA. For TTP, we've known for many years it's due to an absolute deficiency of ADAMTS13, and that's because patients don't produce it because they have a congenital defect that doesn't allow adequate production, or there's inhibition of its action, and that's antibody mediated, and that's almost exclusively in all patients. I can't see this very well. It's a very, very unique situation between ADAMTS13 and VWF. So there's no known specific inhibitor of ADAMTS13. We know that thrombin and probably plasmin has an impact, but the relationship between the two proteins are unique. And as such, it's developed that the cleavage of VWF occurs at one specific spot in the A2 region of VWF. And it's not just that that can happen at any time. It requires shear for the VWF to be elongated, and even thereafter it requires almost clamping of ADAMTS13 onto VWF before cleavage can occur. So the differential diagnosis of TMA is vast, and here are just some of the conditions that we need to consider. But as I said, increasingly there is this importance to try and differentiate TTP and atypical HUS. And there was a suggestion from the French group, a very fair suggestion looking at their data, that you can do this by looking at the creatinine and the platelet count of patients. And if the creatinine is at a certain level and the platelets are greater than 30, they probably will not have a TTP, and therefore you can get on with other therapies such as eculizumab. There's a problem with this. Firstly, not all patients will have neurological involvement, and not all patients with HUS will have an AKI. Secondly, and we know even from the French group, we've got this middle cohort of patients, congenital TTP. And we also know from our own work, but that from our international colleagues, that congenital TTP is not as rare as we originally anticipated and can present in adulthood. So we do require, when we have these cases, to undertake an ADAMTS 13 level. Now that opens up a further controversial discussion about getting this assay done. And can I just say that when you're treating these patients, which will on average cost about £65,000 an episode, to do a test that costs £100, I don't really see that there is an argument that we shouldn't be doing it. It should be available within at least major centres. But moving on, we had a look at the UK TTP registry and tried to determine if there was anything in the French work that would suggest that the creatinine and the platelets levels were useful to be able to differentiate both of these conditions. And you can see from these graphs that in fact 35% of patients with atypical HUS had a platelet count less than 30 at presentation. This has gone a bit wonky. Thank you. And 17% of patients with TTP had a platelet count greater than 30. So you've got a good 20% of your patients already that would be designated into the wrong cohort. And similarly, with creatinine levels, there's about 15% of TTP patients who, by the French definition, would have a creatinine that's within the atypical HUS range. But you can see from this that the ADAMTS 13 is absolutely conclusive in differentiating TTP from other TMAs and HUS. When we look at TTP, we need to try and have some prognostic factors at presentation that will allow us to escalate therapy, and this is quite important. We know that neurological presentation, in particular in patients who present with a coma, occurs in about 10%. So severity is demonstrated. But cardiac involvement is what's going to kill the patients. And they will have a sudden cardiac arrest and they will not be revived from this. It is extremely rare. And the reason for the cardiac involvement is because you are getting clots within the small arteries, and this is within the small artery within the heart. Sorry, this isn't working. But you can see the pink there, which is pure VWF and platelets. And if we measure the troponin at presentation, and in particular in patients who have levels in the ACS region, even though they've not had an MI, they have poor prognostic disease. In fact, they have very poor prognostic disease. We've just had a look at all the registry data, and it's just been sent out for review. And in fact, anyone with a troponin above the normal range really has a far poorer outcome than those who present with a troponin in the normal range. So let's go back to treatment. For decades, the treatment for TTP has been, and still is, plasma exchange, the benefit of which for TMAs far outweighs plasma infusion. Now, with plasma exchange becomes a lot of issues. No less the type of plasma that's used. So within the UK, we don't use standard FFP, we use solvent detergent FFP and have done for many, many years. Now, the rationale for this was, one, the benefit over reactions using standard FFP. We used to transfer patients to solvent detergent FFP, and they really did much better from a reaction point of view. But then we had the whole new variant CJD saga. And when the UK switched to methylene blue for all youngsters born after 1196, we didn't do that for TMAs. We stuck with SD plasma. And that was probably the right decision, because there's evidence from the Spanish group that the outcomes with methylene blue FFP, for reasons that are not clear, are much worse than patients that have standard FFP. Since 2013, we've now got a new type of Octaplas, Octaplas LG, which will automatically be sent to your blood banks. And this has a prion reduction step. And we've had a look to make sure that this new type of plasma, which has this new step, didn't have any further ill effects or downside on the treatment for our patients. And indeed, it doesn't look to be any different. It looks completely comparable to all the Optiplas that we've used in years gone by. So the other change that's occurred over the last 10 years is the use of rituximab in TTP, and this has reduced the time of patients' admission. And of course it makes perfect sense to give a therapy to clear an antibody, and steroids alone are not enough, and patients will exacerbate to a rate of about 60% once steroids are stopped. Now there remains much controversy about the dosing, the timing of rituximab, and we've done all timings and dosings in our patient cohort. We obviously did the work looking at giving rituximab very early on in a patient's presentation. And the benefit for this, in comparison to those receiving rituximab with refractory or relapsing disease, is demonstrated in this retrospective review. So giving rituximab early with plasma exchange and steroids if necessary will reduce the number of plasma exchanges to remission, will reduce the time of admission, and reduce the time to achieving a CR from admission. What doesn't change is the timing of complete remission from the first infusion, which suggests you need about 10 days for rituximab to work. So obviously giving it earlier is better. And there's always the worries about giving rituximab in conjunction with plasma exchange. But again, we've looked at the pharmacokinetics of this, and we've adapted the protocol so we give rituximab every 3 to 4 days. And you really need to get in the third dose of rituximab to demonstrate benefit. Now moving on to another area of TTP, and that's pregnancy-associated TTP. This is some data from the UK registry, and this was only up till May 2015, and obviously there's more, but it makes the point. 10% of all the cases that are sent to us are pregnancy-associated TTP. And we had thought, and it would make sense, that this was an immune-mediated condition. But actually, with the wealth of information from the registry, it became very clear that the majority of cases are actually late-onset congenital TTP. So we put all this data together, and this is a relatively old publication now, but there was 23 patients with 53 pregnancies. And there's some important things within this data that actually is relevant for other conditions such as atypical HUS. So you can see that the live birth rate from the previous obstetric history in these ladies was very low, at 39%. But from the index pregnancy, which was 20 pregnancies, you can increase the live birth rate with treatment, albeit some of these ladies did present in the postpartum period or at the end of the third trimester. But importantly, in subsequent pregnancies, we can achieve 100% live birth rate and an excellent maternal outcome. Now, be under no illusion that this is straightforward. Sometimes it is not straightforward. We do need to deliver a bit earlier. They do need treatment throughout the whole of pregnancy. I'm sorry, this is one reason why I'm not put on the early slot of talks. And this is some pictures of one of our patients, his placenta, who presented at 27 weeks and had to be delivered pretty quickly. And basically what it's showing is multiple infarcts and hemorrhage throughout the placenta, demonstrating that this ischemia has been occurring throughout the whole of pregnancy. And presentation within the second trimester is most common. So what we do is actually treat them with plasma infusion from the time of positive pregnancy test. And this needs escalating, certainly in the second trimester, definitely in the third. And we will ensure that we deliver at least by about 37 weeks. those last 3 weeks of pregnancy really, it becomes too fretful for everybody. So why is this important? Well, one, when I started doing TTP, the advice, certainly not from the UK but elsewhere, was that women that were pregnant that had a history of TTP should have a termination, and that is not how we proceed in the current era. But two, there's definite similarities with complement-mediated HUS and congenital TTP. And in fact, the pregnancy data for HUS is very, very sparse. But we've successfully managed ladies through pregnancy, either with or without eculizumab. And so that's beginning to increase our knowledge base. Now, this is more important. This is what's coming for the future. So Bax930, which is the first recombinant human ADAMTS13. So here we are finally in 2017 being able to dilute to dry powder and give to our patients rather than sticking in a central line, giving them 5 litres of plasma and hours of therapy. We're not quite at that stage, but this is the first part of it. So this data was presented at ASH. And Bax930 is a glycosylated recombinant human ADAMTS13 produced in CHO cells. It undergoes 2 virus inactivation steps, and it's lyophilized in 5 mils, which is fantastic. So the phase 1 study has been completed and should be submitted for publication hopefully by the end of this month. So this was a first in humans. It was made up of 3 cohorts. The first cohort was a very low dose, 5 units per kilo, and that was really just to ensure that there were no issues, which there were not. The next cohort is 20 units per kilo. Now, the reason I'm telling you the dose is because this would be potentially equivalent to the dose one would require for plasma infusion in congenital TTP patients. And again, this was made up of 3 patients. And the third cohort, which was made up of 9 patients, was 40 units per kilo, which is potentially the equivalent of a single plasma volume exchange that we use in acquired TTP. Now, each patient was not, the subsequent patients were not allowed to be started on the trial until the previous one had completely finished entry and follow-up. So they were very cautious to ensure that there were no issues. So the primary endpoint was to look at any serious and non-serious adverse events up to 30 days, but also to have a look at PK data, antibody formation, which of course is very important, and the impact on von Willebrand factor. So we're primarily now going to concentrate on the final cohort, which is the 40 units per kilo, which gives us the most information. But you can see within the 3 cohorts here, the age range is very comparable, primarily Caucasian population, but male to female was relatively equivalent. Now at the bottom, I've just demonstrated a cartoon of ADAMTS13 and where the mutations are in the final cohort, cohort 3. So you can see that they're pretty widespread throughout the gene. So this is quite important data. This looks at the PK from the final cohort. And it does demonstrate some important information. So the half-life is as one would expect. So it's roughly about 3 to 4 days. But I was interested primarily in what was happening in the first 24 hours once we treated these patients. And in fact, the PK people, and I hope David Keeling doesn't ask me any questions about PK data because he's very clever and I'm not. But from the bit that I understand, there looks like there's two half-lives within the treatment that we're giving these patients. And that has been replicated, or we're replicating it in data that we have from plasma. So there's an initial half-life within the first 24 hours, which is about 17 hours. And then there's a terminal half-life of about 57 hours. And that kind of helps us explain physiologically what's happening, because the previous data suggesting ADAMTS13 has a half-life of 2 to 3 days, but you only need to infuse every 3 to 4 weeks, was kind of difficult to comprehend. What I would also say, we need to look at this in more detail, the half-life did alter depending on the mutation, which of course makes perfect sense, because it depends on the amount of protein secreted. But what's the product actually doing? Well, looking at the cleavage of VWF, you can see for the 40 units per kilo, it demonstrated the best cleavage of VWF, and that extended out for as long as we were able to show benefit. And similarly, looking at the ultra-large multimers, there's initial rapid decrease in the ultra-large multimers that went back up to their normal level in these congenital patients, again, roughly associated with the half-life of the therapy. What about safety and tolerability? It was completely tolerated. There was no issues whatsoever. There was 4 apparent AEs. We didn't have any problems at all. And obviously one has to record everything during a clinical trial. Importantly, there was no problems with immunogenicity, so there was no ADAMTS13 binding antibodies, neutralizing antibodies, or HCP antibodies. Now that was only with 1 dose. So the phase 3 trial hopefully will be starting this year. It'll be an international trial. It'll be initially looking at standard therapy, whatever the patients have, and then using repeated doses of recombinant ADAMTS13 with an extension study until it's licensed. Now another interesting therapy that's in the literature is N-acetylcysteine. For those of you that can remember back, this is the stuff we give patients with paracetamol overdose. But it does look to be quite interesting in as much as it does reduce VWF, in particular the ultra-large multimers. It's unfortunate after its initial presentation that more clinical work hasn't been undertaken using this therapy. So we have used it in patients. It doesn't cure them by any stretch of the imagination, but in the sickest ones that we've used this therapy, where we started it perhaps on a Friday evening and thinking they perhaps would not last the weekend, they have. Now whether it's because of this or because of all the other treatments we give them is difficult to identify, and it's probably they are just all working together. The next interesting treatment on the horizon, and certainly again within clinical trials, is anti-VWF therapy. And this is interesting. So it's acting between the point of platelet VWF binding. And there's a number of products that have been on the market. Some have been ditched, others are ongoing, and some are coming through. And why is it important, and what is the treatment? Well, these are called nanobodies. They're very new. They're from camels or llamas, and their antibodies are really quite specific in that they only have a heavy chain. And that is important because it makes them small, pliable, and they're not immunogenic. So the phase 2 trial looking at this therapy in acute TTP patients was presented last year in the New England Journal of Medicine. It was a difficult protocol. In fact, it was a very poor protocol to try and put patients in acutely. But it did demonstrate what we suspected would be the case, and that is that you can achieve a quicker time to normalization of the platelet count. So you can imagine that all the damage is really where platelets are binding to VWF. So the damage being that it will cause microthrombi, but also that the patients are thrombocytopenic. If you block the VWF platelet binding, you will prevent further microthrombi formation. It won't clear what's already there. We require the standard therapy to do that. But also the platelet count goes up very, very quickly. As with all new treatments, and obviously we had no idea what this therapy would do, it was a little scary to begin with, because what you're inducing is a type 3 VWD state. So the RICOFs are actually down to less than 0.1%. The bleeding signal is not significant. And of course that is as we would expect because it's a very prothrombotic condition and no patient required reversal because of bleeding during this trial. So the phase 3 trial is actually nearly finished. It's ahead of time. They've been able to add more patients to it. It will probably be finished by the end of March. And just as a whoop for the UK, we're the highest recruiting country. It will become standard of care. It is important because, of course, we don't have, or we've never had up till now, any therapy that will just make things better acutely apart from plasma exchange and steroids. Now, there's other therapies coming through. We're trying to hit different areas of the pathway, and one of them is bortezomib, Velcade, which we've used in a few cases, which looks to be useful, but we do need to be cautious. What is increasing and what's being demonstrated, certainly over the last year, is the impact of all the new therapies in medicine on causing a TMA, and there is a number of important drugs both relevant to hemostasis, hematology as a whole, and medicine that are causing life-threatening TMAs. That I can't say any more about, otherwise I will get some lawsuit against me because I'm signed some confidentiality agreement. But it does not look like they cause ADAMT13 deficiency. They are not associated with complement defects, but there is severe endothelial damage. So things that are already in the literature are things like VEGF inhibitors. Velcade can cause a TMA. Some patients get better, some patients do not. But you need to stop the treatments and we need to monitor some of these newer therapies coming through. And this is the importance of having a registry in a very rare disorder. So it is a rare condition, TTP. It should be considered in all acute cases of thrombocytopenia. We have greater understanding for the subgroup, certainly in the last 10 years. The treatments coming through will improve the standard of care, and I would hope in 10 years' time I'm standing here telling you that we just give this infusion and that infusion and plasma exchange will be a thing of the past. So they are exciting times. Thank you very much for your attention.